Introduction. Prostate is a tubulo-alveolar and fibromuscular gland composed of duct lined with pseudo-stratified columnar epithelium. Prostate secretes seminal fluid that nourishes and protects sperm. The prostate typically grows during adolescence under the influence of testosterone and dihydrotestosterone. A detailed gross anatomy of prostate. The prostate is about the size and shape of walnut, partially glandular and partially muscular structure, approximately 20 gram in volume, 3 cm in length and 4 cm width and 2 cm in depth. It has 3 surfaces and 5 lobes, and anterior surface, posterior surface and inferior lateral surface, and 5 lobes, anterior lobe and posterior lobe and the median lobe and 2 lateral lobes. Capsule of the prostate. Prostate is encapsulated in a true and false capsule. True capsule is internal and composed of connective tissue, while false capsule is a continuation of pelvic fascia. The capsule measures 0.5 mm in thickness, and these are the zone of prostate. Transition zone. Transition zone is the innermost zone. Transition zone is the innermost zone, and 5% of the glandular tissue is there in the transition zone, and most of the BPH occur in this zone. And then there is a central zone. Central zone is the area surrounding the ejaculatory ducts, and 25% of glandular tissue is present in this. This glandular tissue is very important regarding the carcinomas. Peripheral zone. 70% of the glandular tissue present in this in the peripheral zones is there, and covers the posterior and lateral aspect of the prostate. Palpated on grisly rectal examination, and 70% of adenocarcinomas are found in this zone. Disease of the prostate. Prostatitis, benign prostate hyperplasia, and prostatic neoplasia. Today we are discussing BPH and prostatic neoplasia. A little histology. Types of cell is epithelial cells and stromal cell. Epithelial contain basal cells, secretory cells, and neuroendocrine cells. And stromal cell contain smooth muscle and fibroblast. Secretory cells. Secretory cells are located along the glandular lumen. These are the secretory cells, the tall cell with the nuclear at their base, and takes positive strains are prostatic acid, PAP, and PSA. And basal cells. Basal cells separate secretory cell from the basement membrane, consists of flattened to low cuboidal epithelial cells. These are the reserve cell. Their presence differentiate benign condition from well-differentiated adenocarcinoma, although cancer can retain rare basal cells. These are the basal cells here, and these are lumina. These all are basal cells. Neuroendocrine cells irregularly distributed, and urothelium lines the prostatic duct. Mucins. Normal mucins are neutrals. Most adenocarcinomas secrete acidic and neutral mucins. BPH. BPH is characterized by increase in both glandular and stromal components in the periurethral area of prostate. Chronic bladder outflow obstruction secondary to BPH may lead to urinary retention, renal insufficiency, recurrent urinary tract infections, gross hematuria, and bladder calculi. BPH is histologically evident in up to 90% of men by age 85 years. Histopathology. Hyperplasia of glandular and stromal tissue with papillary birth enfoldings and cysts associated with squamous metaplasia and infarction. Benign begin around the urethra where ejaculatory ducts enter prostate, mostly transition zone. Basal cell layer is continuous in BPH. And stromal changes include increase in smooth muscle fibers, lymphocytes, and ducts, reduced elastic tissues in BPH. Microscopically, benign prostate hyperplasia can involve both glands and the stroma. Though the former glands are more prominent, a large hyperplastic nodule of gland tissue is seen, and this is cystically dilated gland, and these are the stroma still present. At higher magnification, an enlarged prostate has a glandular hyperplasia. These are the glandular hyperplasia here. The glands are well differentiated and still have some intervening stroma. These are the intervening stromas. The small limited pink concretion within the glandular lumens are known as corpora amylaceae. between the lumen of the gland. These are the corpora malacia. Type of prostatic cancers: adenocarcinoma, sarcomas, neuroendocrine tumors, small cell carcinoma, transient cell carcinoma, squamous cell carcinoma, and primary prostatic lymphoma. Today we are discussing adenocarcinoma. Prostatic intraepithelial neoplasia. Architecturally, pain consists of benign prostatic acini or duct lined by the cytologically atypical cells. There are two types of pain: low-grade pain and high-grade pain. Diagnostic reports should not comment on the low-grade pain. Pathologists cannot distinguish between low-grade pain and benign prostate hyperplasia. The incidence of high-grade pain on biopsy is 4 to 5%. The distinction between low-grade pain and high-grade pain is based on the prominence of the nucleoli. The risk of cancer is 20 to 30% on subsequent biopsy within the 1 year after diagnosis of high-grade pain. High-grade pain is a precursor lesion to many peripheral intermediate to high-grade adenocarcinoma of the prostate. Histology of adenocarcinoma of prostate. There are 5 patterns observed on the biopsy in adenocarcinoma of the prostate. And in the pattern 1, there are the small uniform glands. Well, these are small uniform glands. And in pattern 2, there are more stroma between these glands. They are closely packed, but there are stroma between the glands. In the grade 3, there are distinctly infiltrate margins there. And in 4, in pattern 4, irregular masses of neoplastic glands. And in 5, only occasional gland or formation is here. The Gleason system is based on the granular pattern of the tumor. Architectural patterns are identified and assigned a grade from 1 to 5, with 1 being the most differentiated and 5 being the undifferentiated. Here are some patterns. This is the pattern 1, Gleason pattern 1. The cancerous prostate closely resembles to the normal prostate tissue. The glands are well formed, closely packed to each other. This corresponds to a well differentiated adenocarcinoma, a well differentiated carcinoma. This is Gleason pattern 2. The tissue still has some formed gland there, but they are larger and have more tissue between them. They become a little larger and there is more tissue between them. This is the pattern 1 and this is pattern 2. You can see they have more tissue between the glands. This corresponds to moderately differentiated carcinoma. In this pattern 3, the tissue still has recognizable glands. There are some glands here. We can see these glands, but the cells are darker. The cell becomes darker, more darker than before. Some of these cells have left the gland and are beginning to invade the surrounding tissue or having infiltrating pattern here. This is all infiltrating pattern. This corresponds to moderately differentiated carcinoma. In Gleason pattern 4, the tissue have few recognizable glands. Here, the white color, we can see the glands. Few recognizable glands. Many cells are invading the surrounding tissues here. Tissue in neoplastic clumps. Cells become just clumpsing there. All cellular clumps. Irregular cribriform gland with stromal lumina. We can appreciate cribriform glands here with small round lumina inside them. These are the typical features of pattern 4, the cribriform glands. In pattern 5, the tissue does not have any or only few recognizable glands. We cannot recognize glands here, but few glands here, white lumina. We can see the glands there. There are often sheets of the cell throughout the surrounding tissue. Single cell infiltration. This corresponds to anaplastic carcinoma. The presence of comedonecrosis in a cancer space is sufficient to diagnose Gleason grade 5. This is the comedonecrosis between the lumina of the gland. In the presence form of Gleason system, prostate cancer of Gleason 1 and 2 are discouraged in biopsy reporting. Gleason pattern 3 is by far the most common. Score and prognosis. The pathologist then sums the pattern number of the primary and the secondary grade to obtain the final Gleason score. If only 2 patterns are seen, the first number of the score is the tumor primary grade, while the second number is the secondary grade. If 3 patterns are seen, the first number of the score would be primary grade, and the second number the pattern with the highest grade. For example, if the primary tumor grade was 3 and the secondary grade tumor was 4, but some cells found to be grade 5, the Gleason score would be 3 plus 5, that is 8. This is a slight change from the pre-2005 Gleason system, where the second number was the secondary grade. Here the Gleason score 7, we can appreciate the Gleason pattern 3 in this slide and some Gleason pattern 4 in this slide. So the score will be 3 plus 4, that is 7. In this slide we can appreciate a Gleason pattern 4, and the most dominant pattern is 4 and the second most is also 4. So 4 plus 4 is 8. In this slide we can appreciate the Gleason pattern 4 here and a little bit Gleason pattern 5 here. So the most common is the 4 pattern, and then the second most common is the pattern 5. So it's 4 plus 5, that is 9. And in this we can appreciate a sheet of cells, and this is pattern 5 throughout the slide, and we cannot appreciate the other pattern. So this most common is 5 and the second most common is also 5. So the grade is 5 plus 5, that is 10. So another slide we can appreciate, this is pattern 3. You can see here the glands, and there is no other pattern we can appreciate. So the 3 plus 3, the most dominant pattern is 3 and the second most dominant pattern is 3. So the 3 plus 3 is 6. In this we can appreciate the pattern 3 here and the pattern 4 here. The most common pattern is 3 here, with minor component of capriform glands here. So it's 4. Capriform, if we can form the capriform glands, is grade 4. So 3 plus 4 is 7. Here we can appreciate another slide. This is the 4 grade with most dominant, and the second most dominant is also 4. The 4 plus 4 is 8 with poorly formed glands. We cannot appreciate well glands, but we can see their glands white little bit far apart. This is the Gleason score 5. We can appreciate the pattern 5 here, everywhere. We cannot find other thing. There is this sheet of cells all over the slide. So the most dominant pattern is 5 and the second most dominant pattern is also 5. So the Gleason score is 5 plus 5, that is 10. High grade disease. Another high grade disease, this Gleason score 10, we can see we cannot appreciate the gland here. So this all is pattern 5, and with most dominant 5 and second most dominant also 5 with individual cells. Gleason score 10. 5 plus 5, 10. ISUP grading. In the 2014, the International Society of Urological Pathology released supplementary guidance and a revised prostate cancer staging grading system called ISUP grading groups. In this group, they divided the Gleason score in 5 groups. In group A, they take all the cancer which Gleason score 6. We put in this group, grade 1. This is less aggressive and low risk in this group, in this grade. In group 2, they put 3 plus 4, that is Gleason score 7. 3 is a low disease than the 4. The most pattern in this group is 3 and the second most common is 4. 3 plus 4 is 7. Slightly aggressive but slow growing, low to intermediate risk in this group. In group 3, we can appreciate the most dominant pattern is 4. The second most pattern is 3. So 4 plus 3 is 7. We put in grade, they both are 7, but we put this in grade group 2 and this 7 in grade group 3 because the first pattern is 3 and their first pattern is 4, the high grade disease here. Grade group 3 is moderately aggressive, fast growing and intermediate to high risk in this group. And grade group 4, this one is Gleason score 8. This is more aggressive, rapidly growing, and high risk in this group. In grade group 5, Gleason scored 9 or 10. It can be a 4+5 or 5+5, 10, and it is highly aggressive, rapidly growing, high risk disease. Now, some of these slides. Angiolymphatic invasion, not commonly seen, and calcification, more common in benign than the malignant prostate, but present in Gleason pattern 5 with comedo-type necrosis. Cellularity of vessels. In radical prostatectomy specimen, increased vessel cellularity may be associated with higher grade tumors. And corpora myelitia, benign but may be found in the tumor. This is the corpora myelitia. This is the lumen of a gland with basal cells there. This is corpora myelitia. Many may arise from the release of prostate secretory granules, remnant condensed to form eosinophilic bodies. They are also known as prostatic concretion. Corpora myelitia are rich in aggregated proteins. Crystalloids resemble benzoin crystals seen in the lumina of 10 to 23% of carcinomas, usually grade 3. Rarely seen in benign glands or metastatic foci, composed of inorganic sulfur, deeply eosinophilic rhomboid. Mucin. Acidic mucin found in lumina in two-thirds of cases looks basophilic or deeply eosinophilic. Confirmed with Asian blue or colloid iron stains. Normal prostate secrete neutral mucin, although acid mucin can be seen in adenosis and prostate radiation therapy. Perineural invasion, common in 85% of the tumor. When present in the neural core biopsy, suggestive of extraprostatic extension. Diameter of the perineural invasion may be prognostic factor, may mediate local tumor spread by the tumor expression of nerve cell adhesion molecule. Now, reporting of a prostate biopsy. Pathology of prostate needle biopsies. How to process? Prostate core biopsies from different sites are processed separately. The number and the length of cores are recorded. To achieve optimal flattening and alignment, a maximum of 3 cores should be embedded per tissue. Recommendation terminologies for reporting prostate biopsies are benign, negative for malignancy, if appropriate include a description. Active inflammation, granulomatous inflammation, high-grade prostatic intraepithelial neoplasia, high-grade pain with atypical glands, suspicion for adenocarcinoma, focus of atypical glands, lesion suspicion for adenocarcinoma, atypical small acinar proliferation, suspicion for cancer, adenocarcinomas and intraductal carcinomas. Each biopsy site should be reported individually, including its location and histopathological findings. Intraductal carcinoma, lymphovascular invasion, and extraprostatic extension must be reported in each biopsy score. A prostate biopsy that does not contain glandular tissue should be reported diagnostically inadequate. Mandatory elements to be reported for a carcinoma prostate biopsy are type of carcinomas, primary and secondary, worst Gleason grade, percentage high grade carcinoma, extent of the carcinoma, if present, extraprostatic extension, semivesicles invasion and lymphovascular invasion, intraductal carcinoma, capriform pattern, perineural invasion, and ISUP grade. This is a biopsy report reported in SIUT, and this is a 12 core biopsies taken from different side of the prostate gland, and each core is mentioned separately, and each core's length is described separately. This is a core 1, and its length is defined separately. And we can see in the first core, prostatic adenocarcinoma, grade 4. In the first core, the most dominant pattern was 4. So they write first the 4, then the 5. The second most common pattern was 5. In 60% of the core with foci of perineural invasion. Perineural invasion also mentioned in each course. If there is an invasion, then it will be mentioned in each and every core. In the second core, we can see grade 4 disease only, and in 70% of the core with foci of the perineural invasion. Similarly, we can see here single core prostatic adenocarcinoma, 4+4 in 70% of the core with no invasion. to the periphery. In this 12 core biopsy, we can see mostly in each course the grade 4 disease. In some ways, there is a grade 5 disease, 1, 2, 3, in 5 cores. So the Gleason grade will be 4 and plus 5, that is 9. Thank you, sir.
Now, there is an improvement in this report, if you go back to the last slide. And this improvement is not recent. It is something which was proposed, I think, in 2014 EAU guideline. And it is now also written in the textbook, our own textbook, that is Campbell's Urology, that in order to know the malignant potential, which was actually the purpose of putting this kind of a scoring system, it is rather important to group the grades by just defining a grade will not give you something. So a score was added to it so that the whole magnitude is in front of the clinician. Now again, statistically that was not proving something which was of value, so a group grading system was introduced. Now how they group it? For instance, anything which is less than 6 score is not regarded something of importance statistically according to the malignant potential. The group which is 6 or equal to 6, it is regarded as group 1. Anything which is like 3 plus 4, 7 is group 2. 4 plus 3 is group 3. Again it is 7. 8 is regarded as group 4, and then 9 and 10 is group 5. So in that way they have put together or clumped together the individual grading or scoring, so that statistically speaking it has got some value and which has to be taken into account whenever something like a biopsy report is in front of somebody who wants to deal with it. For instance, there has been a lot of criticism on certain surgeons that they have operated radically on people having higher grades or higher scores rather. Those surgeons were not of at fault, as my understanding is, because they were not actually reflecting upon this report whenever they opt for radical prostatectomy, for instance. They were actually not seeing the malignant potential. Potential means what happens maybe 2 years down the line or 3 years down the line. What they were seeing actually was the stage of the tumor. If it is organ confined, which can be seen on an MRI, then they were pretty sure that whatever may be the score or the grade groups, they have to act upon it, take away the prostate, and then let the nature decide the future course of the disease or the patient. Now, this is something which is of interest because there is always a difference of opinion. For instance, some of the surgeons, if you go back maybe 2, 3 years, 5 years, in the literature, they were of the opinion that we were having radical surgery for these patients so that if there is anything which is like oligometastasis, that has been taken care of. Now, if there is no oligometastasis at this point in time, again, radical surgery, masking anything which is on the biopsy report is beneficial to the patient. Again, in terms of a country like us, Pakistan, maybe a third world country, where there is not much compliance as regards follow-up, this thing was taken as something of say a green card, meaning to say you have to operate in any patient. If it is organ confined, don't take into consideration something like this. And this was some a part of the practice of a lot of people in this part of the world. But you see, whenever you move from one paradigm to another paradigm, meaning to say, if you screen your patient, you know the magnitude of the disease in a given population, you know that a lot of people in your perspective, in your country, wherever you are actually practicing, is too enormous, then you got to devise a strategy which is different. Now, since West has got this kind of statistics available to them, so they have devised everything which is available in terms of future prediction. Like this one, this is a future prediction report. It will not give you anything right now in terms of staging. It will give you only the grading kind of expression. What it will give you is something which will happen next. But what's the position at this point in time, it can be picked up on an imaging, not by biopsy report. So you see, if you happen to work in a country like us where we don't know what's the incidence of the disease, we don't know how many patients are there, where we are still searching, we can't go on to screening, we can't go on to something called mass filtering of our patients. We always have lesser amount of people who fall into the category of radical prostatectomy, for instance. Then the things are different. We have to think a lot, not following the way the West is going, because the West is going sequentially. They have evolved their system. We haven't evolved our system. We are still far behind. So, last word from your side.
This is actually the prostate is the gland which generates cancer in different stages of the disease. Like that, and this is why Gleason scoring system was generated to depict the prognosis of this disease. Different glands of this disease are at different stages of the cancer. That's why this scoring system was generated to clearly define the stage or prognosis of this disease in this score system. And understanding this scoring system is very much important regarding the prognosis of the disease. And once again, when we were dealing with the foreign delegates in the workshops, this was very much important, that what is the volume of the disease in the prostate, and at which location or which lobe was involved more. So it is very much important that we have to make a solution for this biopsy reporting and biopsy taking. This is my take on this.
Thank you, sir.